one of my roles in primary care sports medicine is treatment of concussions, and I'm the director of our concussion center. So I wanted to talk a little bit about evaluation management of student athletes. That's where my expertise really lies. So I'm grateful for this opportunity because I think that one of the things that's plaguing treatment of concussions in this country and internationally is kind of a dearth and lack of widespread disseminated knowledge about how do we properly deal with concussions. So I'd like to kind of, over the next 10 minutes, take you on this journey from moment of injury to office evaluation and recommendations to kind of hopefully share some information about what we know, what we don't know, and how we treat these student athletes.
Sorry, I'm just going to steal my drive over here. I apologize on interrupting. Forgive me, guys. Sorry.
No worries, no worries. So I'm grateful for the opportunity to often cover a lot of sporting events, so I will often see these incidences happen in person. Some of you in the audience may also be sharing that role sometimes as sideline providers. So basically, concussions are very complex, but the role of the sideline provider is very simple. So if you see an accident or an injury that is potentially concerning for a concussion, so concussions can be sustained most often via direct blow to the head, but sometimes via whiplash mechanism as well. So there's two questions that you need to answer as the provider on the sideline. Do you think that student athlete has sustained a concussion? And if so, they have to be removed immediately, evaluated, and if your suspicion is strong enough, absolutely no re-entry into that same game the same day. And two, are you concerned for something more serious than a concussion going on, in which case do they need to go to the hospital? The only scenarios in which a student athlete or anyone needs to go to the hospital is in the situation where they demonstrate some red flag symptoms. So as part of my evaluation, I'm always checking for these particular signs and symptoms that suggest that this is not just an ordinary concussion. Potentially there's something more dangerous, a skull fracture, an intracranial hemorrhage going on that would require urgent evaluation. So I'm looking for things like unequal pupil size, drowsiness or inability to wake up, persistent or worsening headache, slurred speech, weakness, numbness, decreased coordination, repeated episodes of vomiting, convulsions or seizures, any unusual behavior. And this is a very subtle one, but sometimes you'll find that they're just very agitated beyond that which they would normally be acting. That can sometimes be a very subtle sign of some impending doom. And then certainly any loss of consciousness is one of the easier signs to recognize, right? And there's no hard and fast rule on how long a student athlete needs to be have lost consciousness for the requirement of an ER evaluation. Certainly anything longer than 20, 30 seconds, which feels like an eternity on the sideline, would require that. I'm also going through kind of the standardized concussion assessment tool. It's the most universally accepted and standardized assessment tool that we have in terms of concussion assessment. And as I said, the most important thing that you can do, even if there are slight suspicions, whispers that a student athlete has sustained a concussion, the worst thing you could do for that kid is let them go back into play. The feared complication is something called second impact syndrome, which is when they sustain a second head injury, potentially can be fatal. So I like to bring them into the office as soon as possible because treatment really begins as quickly as we can get them. I think that there's been historically this move to kind of, some of you may be familiar with the concept of cocooning, where after someone sustains a concussion, the recommendation is, just kind of don't do anything, no screens, no activities, lock yourself in a dark room, no stimulation. And what we know is not only is that not helpful toward recovery of concussion, but it can actually be detrimental and it can slow down recovery. So I like to see them as quickly as possible, hopefully a day or two. I recommend rest, take it easy for 24 hours, and then come on and see me or start to get things moving. So in the initial visit, I'm getting, of course, a history. I'm looking at certain things like when and how did it happen, certain prognostic factors. Was there loss of consciousness? Is there amnesia related? Do they remember the events or not? Those are poor prognostic factors that indicate a potentially prolonged recovery. Who were they evaluated by? Was there any imaging performed if they went to the emergency room? Have they had concussions before? what happened those last times they had concussions. How long did it take to recover? Was it a week? Was it 5 months? Those are all very important information for me to have. I'm also looking at some things that a lot of people don't necessarily associate with concussions, but also are prognostic factors. So things like, is there a personal family history of things like learning disability, ADHD, developmental disorders, any mood or psychological conditions such as anxiety, depression, OCD? Are there a history of migraine headaches? Things like that. Do they use visual aids, contacts, glasses? These can all help provide pieces of information that for me are all various pieces of the puzzle in putting together that particular individual and that particular concussion, because all individuals and all concussions are slightly different. I'm also doing a physical exam. Of course, I'm doing a basic neurological exam, making sure that there's no focal findings that would be concerning. Careful head and neck palpation, looking for any potentially missed fractures. I'm also doing a musculoskeletal exam. Do they have full strength, range of motion of their neck? As I said, there's often a whiplash component, so it's very much common that there will be concomitant neck pain and neck injuries with decreased range of motion. So I'm looking for all those things. And then I get into the little bit more nuanced portion of my exam. I start with the VOMS. Some of you may be familiar with that. So basically what that is I'm assessing the vestibular and the ocular motor systems. So I do this via various tests and mechanisms. I'm tracking their eye movements. Are they moving smoothly? I'm checking their convergence. So I bring my finger toward their nose. If it's beyond a certain distance, that's called a convergence insufficiency, and potentially that's something that's amenable to further treatment with corrective lenses or ocular therapy, things like that. I'm looking for abnormal skipping of the eye, that's called saccadic movements. And I'm also looking at something called the VOR, vestibular ocular reflex, in which I'm having their eyes fixed on a certain point, and I'm having them turn their head side to side and up and down, and I'm seeing, most importantly, does that elicit symptoms? That's the most important thing for me. The other thing you'll often see is slowed ocular movements, where maybe it doesn't necessarily elicit symptoms, but as we know from concussions, which generally just create this slowing of all things, we can especially see that in eye movements. I'm also looking at something called the Standardized Assessment of Concussion, the SAC. So that's, I'm sure, something that a lot of you have come across. Basically, I'm doing the standardized orientation questions, and then I'm assessing their memory and concentration and focus, because those are also various ways in which concussions can create abnormal functionality in individuals. So I'm asking them various, repeating after me. I'm going to give you 5 words, repeat them back to me 3 times in a row. Remember those 10 minutes from now. I come back 10 minutes later. How many of them do they remember? I'm asking them to repeat numbers in reverse order to me. I'm asking them to go through the calendar starting with December in reverse order. Challenging for a lot of people at baseline. So at at that first appointment, for me, that's also a way to kind of get to know these individuals and can I get a baseline assessment. I'm also doing something called the balance error scorer system, where basically I do a modified version. So I just do the top 3, A, B, and C. I'm checking their balance, looking for things like ataxia, which has been a very hot button topic, especially with the Tua Tagovailoa incident in the NFL. If anyone has kind of followed with any of that, I'm still trying to make sense of the NFL policy, so I may not have a great answer if anyone asks me about it, but that's something that we routinely look for, because we also know that concussions can affect balance. So then it comes time to put all of these puzzle pieces together, right? We define concussions based off of the predominant symptomology that are created by the concussions, right? So there's various subtypes. Do they have headache predominant? Do they have a lot of neck pain, which is cervicogenic? Vestibular, ocular motor, sleep disturbance. These are all various ways in which concussions can create these abnormal symptoms, and by no means are these symptoms mutually exclusive. I often see patients with, symptoms that range this entire spectrum. But it can be helpful because it can help to gear treatment for that specific individual. Now, I'll be honest with you, with most people, the symptoms go away with time and without very much intervention. The expected recovery timeline that I always talk about with my patients, adults recover a little faster, so we give them up to 10 to 14 days. Beyond that, then we say you've developed persistent post-concussive symptoms. Kids, adolescents, we give them even more time, up to 28 days. We know that 90 to 95% of individuals are going to recover without a lot of extra interventions without that expected timeline. It's for those patients that have those persistent symptoms where these various therapies and additional interventions that I'll touch upon can really play a huge role. For student athletes, the primary goal is always getting them back to school first, right? They can't get back onto the playing field before they are fully back at school, and it's not enough just to be tolerating school. They have to be back at school without any significant limitations or issues. It's not uncommon that they'll go back to school and they'll lose focus after 30 minutes in a 50-minute class, or their headache starts to come on in the afternoon because they've been trying to pay attention all morning and it's just too much for their brain to handle as they're trying to recover. So one of my roles is providing various suggestions for academic accommodations that hopefully are very short term, but can ease with that transition back into the learning environment. Unfortunately, I still sometimes see patients come to me, they had a previous concussion, they saw a pediatrician, local provider, they said, oh yeah, take 2 weeks off and then go back. And there's no evidence to support that. And it always pains me when I see that because that student athlete missed 2 weeks of school that they didn't necessarily need to, right? So for me, it's all about increasing exposure load and managing those symptom exposures based off of how you're feeling. So I recommend things like, just jump ahead here. So there's the Return to Learn plan, which is very commonly accepted by providers across the country, promoted by the AAP. So, we suggest things that can help with this transition. Maybe you need to take frequent breaks throughout the day. Maybe you need to leave class 5 minutes early to avoid the hustle and bustle of the hallway, which can be overstimulating and can exacerbate symptoms. Maybe for a week or two, you need to eat lunch by yourself in a quiet environment and avoid the cafeteria. I also make recommendations to teachers. Can we try to reduce the workload? Can we give them extra time? Things like that. Then there's the return to play protocol. So once they've satisfied that they have successfully returned to school without issue and they are asymptomatic, then there's a standardized return to play protocol that we follow, and we'll discuss that in a couple slides. Some other various things that I'm always touching upon in my initial meeting with these athletes. First of all, if they're of driving age, always make driving recommendations. So driving can be really tough and challenging in concussion because, as I said, it can affect your eyesight, and driving necessitates the tracking of very fast-moving objects, which in and of itself can elicit symptoms. So if they have to drive, then I recommend daytime local driving and avoidance of nighttime and highway driving because those are the more potentially dangerous scenarios. I also am frequently and constantly talking about proper sleep hygiene. Kids cannot recover from a concussion if they're not getting adequate sleep. Adolescents, as we know, are terrible sleepers anyway, right? So they need constant reminders that you should be getting 8-9 hours of sleep, and I'll make various recommendations about how we can optimize the sleeping environment so that we can attain that goal. Proper diet, lots of fluids, and maintaining hydration are paramount. One of the most important things, and this is the biggest reason why I like to get them in early, is because thanks to John Letty's work up at Buffalo, we now have a plethora of evidence supporting the usage of early symptom threshold light physical activity and its role in the rapid recovery of concussions. So basically what that means is we like to get these athletes getting started on day one, essentially, with some light movement. Not anything serious. We're talking walking, stationary bike, some light swimming. And what I counsel these patients is, I want you to give yourself an overall symptom grade before you start. Say your overall symptoms are a 3 out of 10. I want you to go for a walk, a bike, or not a bike ride because head injuries, stationary bike, or a light swim. And when you feel like your symptoms are approaching that 4 or 5 out of 10, stop, relax, reset. Do a little bit every day. It may be 5 minutes, it may be an hour. Everyone's a little different. You have to go based off of how you're feeling. Last thing is, I'm not a huge medication proponent. I will recommend Tylenol, Advil as needed for headache management. I'm also constantly seeing the role of medication overuse and the risk of rebound headaches with particular, motor vehicle accidents, for example. They have a lot of other things going on. They're taking Tylenol and anti-inflammatories to manage their pain. They have these persistent headaches. Potentially there is this component of a rebound headache where their body has become dependent on that medication to prevent a headache, and now it's needing that. So it's very important that if they don't need to be taking something, that they really don't need to be taking something. Sleep, as I said, also very important. Melatonin, also something I'll commonly recommend if their sleep is really disturbed beyond 1 or 2 weeks. Oh, sorry, that should say return to play. So this is the graduated return to play protocol. Depending on the stage and level of the athlete, I like to kind of communicate with various school ATCs. For younger patients, it's a little bit more of a challenge in getting a trained adult to kind of oversee this return to play protocol. But basically the way that this works is it's a graduated increasing level of physical exertion and an observation of, does that increased level of physical exertion exacerbate symptoms? So it starts with light aerobic exercise, which correlates with that light activity that I was talking about. So another benefit of this, especially music to high school football, players' ears, is I'm already getting you started on this protocol, so we're getting you one step closer so that as soon as you're ready to go, we're going to get you back quickly and safely. The way this is designed is that each stage takes 24 hours. So you do this, you perform this level of exertion. If there's symptom exacerbation either during or for the following 24 hours, that's okay. That just means that their body is not quite ready to progress, and what that means is they need to rest. The next day, they restart at the same stage. If they don't experience any symptom exacerbation, then they get to go on to the next stage. The penultimate stage is they're engaging in full contact practice. If that goes well, then they're cleared for return. So I talked a little bit about these more challenging cases of persistent post-concussive symptoms. So these are the scenarios where, to Dr. Vitale's point about the power of collective intelligence, there is no I in the role of these patients, right? I see a lot of nodding heads in the back. I'm assuming we have some therapists back there who treat a lot of concussions. So, I mean, the role of therapists and other providers in the treatment of these more challenging concussion patients is paramount. I alone am not good enough to get these kids back to where they were. I'm constantly sending them to physical therapy for rehab, targeting their neck, their vestibular system, their ocular motor system, working on this concept of exercise intolerance, which is basically early onset fatigue that's induced with exertion. And then based off of what subtype of concussion I've diagnosed them with, there's also potentially roles for referrals to other types of providers. So for those student athletes who are having a particular issue with school, having cognitive symptoms, difficulty with focus and memory and concentration, in particular if they have a history of ADHD or learning disability, there's a great role for neuropsychologists. If they have persistent headaches, I'll send to neurology. If they're having a lot of difficulty with sleep disturbance, potentially send them to a sleep medicine specialist. I think one of the kind of more subtle presentations is that of mood disorders. So patients that have persistent anxiety, depression, sadness, irritability, which are common after a concussion, there is an excellent role for psychology and specifically cognitive behavioral therapy in the treatment of these patients. Unfortunately, this country is suffering from a severe lack of available mental health providers, and in particular PhDs, who are usually the ones that are capable of providing CBT. But we do the best we can to get those particular patients in and try to get their mood symptoms under better control. And lastly, for those that have persistent ocular issues or balance issues, I'll send to ophthalmologists or neuro-ophthalmologists or behavioral optometrists who can do more in-depth testing of those eyes and see exactly what might be needed in terms of corrective lenses, ocular therapy that's a little bit more nuanced, things like that. That's everything. Thank you.